Hello, everybody. It's my great pleasure to introduce this seminar organized by the Gen and Kidney Group and the Young Nephrologist Platform. So I will introduce the speaker and the panelists of this webinar and myself. So I'm Lucile Figueres. I'm an adult nephrologist interested in genetics, and we're working in Nantes, France. And we will have the pleasure to hear Claudia Izzi. Claudia Izzi is working in Brescia in Italy. And she worked in medical genetics clinics for a long time and have a lot of papers on ADTKD in ciliopathy and a lot of work in genetics. She will talk about how to understand the result of a genetic test. And then we will take your question and discuss with two great panelists, Albertien van Eerde, who work in the Utrecht in the Netherlands, and who I have the pleasure to work with in a Gen and Kidney group. And Beata Lipska, professor in Gans in Poland, who will also join this panel. So, Claudia, when you are ready to start, we'll have a pleasure to hear you.
So, thank you very much for this kind invitation. I am very happy to be here to speak about genetic test result and how to read it. And I thanks the ERA working group of genes and kidney. And I have no disclosure. And why are we talking about genetic test? We know since 2019 from this beautiful paper from the group of Professor Garavi that monogenic kidney disease are relevant as a diagnosis in chronic kidney disease patients. This is a work paper on exome analysis on more than 3,000 patients. And as you can see, the main genetic disorder are ADPKD with variants in PKD1 and PKD2, and Alport syndrome with variants in the different genes called 4A4, called 4A3, and called 4A5, and uromodulin as a third cause, and uromodulin is responsible of ADTKD, autosomal dominant tubulointerstitial kidney disease. And then we have all other forms of monogenic disease. So genetic testing is important in our diagnostic workflow in our patients with CKD. So the topics of my talk will be some genetic basic information. Then I will talk about how a genetic test report is in the different information that we should find, and some clinical cases. So I remember that our genome is organized in chromosome in our cells, and the chromosome in our cells are in number or 46. And here you can see a karyotype. We have 46 chromosomes. They are all in pair, 22 autosomes. And then we have sex chromosome, X and Y, in most male patients, male person, and double X in female. And each chromosome contains a lot of DNA. And okay, I'm trying, okay. And these are the genes that are formed by intron and exon, and all the exon of our entire genome represent the exome, and the exome represent 1% of all genome, and our pathogenic variants lie, the most of them, 85–90% lie in this coding region of the genome. And in each genome, we have to remember that we have about 5 million variants. And so we have to understand which is the one that we are searching in our patients. The type of variants can be divided in two main groups, DNA variants and chromosomal variants. DNA variants, here is a list of single nucleotide variants and deletion and insertion. Here you can see mean-sense, nonsense, frame shift, synonymous variant, and copy number variant that are small chromosomal structural variant where we have gain or loss of DNA segment. And this slide, this couple of slides, just to remember that the description of sequence at the DNA level and at protein level should be accurate, unambiguous, and standardized. So these recommendations are important, I think, for all of nephrologists to understand the description of the variant on a genetic report. And here an example of the protein level description of the variant. Then I remember that the variant can be present in a heterozygous state. We said that we have our chromosome in pair, so also our gene in the autosomes are in pair. And if we have only one variant in one copy of the gene, we will have a heterozygous state, while if we have two different variants, we will have a compound heterozygous state. And if the variant is the same, we have a homozygous. And finally, hemizygous state is when we have a variant on X chromosome in a male patient. And the type of inheritance of diseases are nicely, I think, represented in X-linked. In Alport syndrome, we have in Alport syndrome X-linked inheritance when we have variants in COL4A5 on the chromosome X, but also we have autosomal dominant Alport syndrome. You see here heterozygous state of the variant to have the disease. But also we have autosomal recessive inheritance when the affected person inherited both variants from father and the mother. And we can also have digenic inheritance, that is another complex inheritance in genetics when we have two variants in two different genes. You can see here two different variants in the two allele or in the same allele if we have a cis configuration. So what are the essential point that we should find in a genetic test laboratory report? Here you can see different section and the data of the patient and data of the laboratory test, but also the date of report. And this, I think, that is very important to look at because it say to us the moment, the knowledge in which at that time has been interpreted our genetic test. And then we have a section on the type of test. So the sample type, usually peripheral blood, but we can have also DNA or RNA. The type of test here is the list. We can have Sanger sequencing or MLPA, chromosomal macroarray for CMV. Then we will see NGS analysis in multi-gene panel or whole exome or whole genome sequencing. And this is the list of type of genetic tests that we can have. And I have specified the type of variant that we can identify because it's not the same for all type of tests. And we have to choose the right test based on the type of variants that we wanted to identify. And Sanger sequencing, for example, we use this type of genetic test when we want to search for a small variant that we know, for example, in a segregation analysis in a specific DNA region, exon of a specific gene. And if we look for small rearrangement in the gene, in a specific gene, we will use MLPA. And if the rearrangement are larger, we will request for chromosomal macroarray. And targeted next generation sequencing gene panel are useful when we want to look for different genes that are responsible of the same phenotype, while whole exome sequence will look at all the coding regions of the genome. And if we want to look at also non-coding regions where also lie some pathogenic variants responsible of disease, well, we should ask for a whole genome sequence analysis. Here I show you some of kidney disease multi-gene panels, so we can have a small gene panel or large gene panel. Here you can see for glomerular disease or ADTKD, CACUT, ciliopathies and cystic kidney disease or ADPKD. But we can also have larger panel that take together all the kidney genes. And this table just to show that for each type of genetic test, we cannot see all the type of variants that we have in our coding sequence or genome. And then there is a part in the laboratory report on test methodology. These are technical information about the type of analysis of the instrument and so on. And then there is a part that is very important, that is the reason for request. So the phenotype of our patients, in this case, we are talking about renal disease patients. So I made just some example. And these are information that clinical information are important, and because the type of interpretation is filtered also on the base of the clinical phenotype, and then the clinician that refer the patients to the laboratory. But if we look so at the result, what can we have when as a result? In this case, it has been performed a ADPKD gene panel. And we have that in the laboratory report, we should have the gene. So we have PKD1, the type of disease related to the gene, and the type of variant. And it is important that the type of nomenclature used, and you should find both the cDNA variant and the protein variant. This is important for interpretation of the genetic test report. And then the type of inheritance pattern, the zygosity, in this case, the variant is in a heterozygous state, so the patient has also one normal allele, and the variant in no data on the parents, so we don't know if it's paternal or maternal inherited, and then the variant classification. In this case, we can see in the comments that the variant is in exon 4 of the PKD1 gene and is reported as a pathogenic, so class 5 according to the ACMG standards. And this variant is also reported in the disease reference database, ADPKD variant. This is important because we have different database, disease database that can be used to look at if the variant is already reported or not. This is important for classification of the variant, and also is present in ClinVar and is also described associated with the disease in this paper on human mutation. And then usually you will find that genetic counseling is recommended to explain to the patients the result of the analysis and the interpretation of it. In this case, the result is PKD gene, is ADPKD, and the variant is a missense variant in a heterozygous state and in exon 14 of the gene, and it's rare, not reported in the ADPKD variant database nor in ClinVar database, and no segregation data are available. So the variant is classified as a variant of uncertain significance, a class 3. And again, genetic counseling is recommended. So here, just to remind you that there are guidelines for the interpretation of the sequence variants, and these are ACMG standard guidelines published in 2015, and now I think that at the end of the year we will have an update of these standard guidelines for the interpretation of sequence variants, while these are the technical standards for interpretation of copy number variants. And here you can see the different class criteria that are used in defining the variant. We have different combination, as you can see here, to have pathogenic, likely pathogenic, or benign or likely benign. And when we do not have these criteria, we will have a variant of uncertain significance. So this is a simplified 5-tier classification system. And again, the unconclusive results that are difficult for clinician to deal with. So if it's a VUS, so a variable of uncertain significance, what we should do. It's important to remember that it should not be used in clinical decision making, and ACMG recommends follow-up testing to have additional evidence, and maybe we can reclassify the variant, and maybe it will become a likely pathogenic or a likely benign variant. Some examples of new evidence to reclassify are functional studies of the variants or of the variant that we have identified, or other variants, additional variants of the same type reported. And last, new affected individual or family segregation. And this is one of the way we usually in a clinical setting try to classify the variant, testing other affected and unaffected patients in the family. So looking at some clinical case, I show here an example of a patient. Here we have a father and a son. The father had a clinical picture of ADPKD. We can see here enlarged kidneys with multiple cysts, and we thought to ADPKD. In the son, there was However, a very early onset disease at 2 years of age with polyuria and a renal biopsy revealed a possible nephronophthisis. And this imaging is at 34 years of age, and he had normal kidney volume, but some cysts. So we have performed for the father ADPKD gene panel and MLPA analysis, and we didn't find any variants related to the phenotype. And in the son, we tested for a larger panel with kidney cystic genes. And what we have found is that the patients, then we tested also the father, so also the father had the same variant. He had a variant in HNF1 beta. And this is the variant, and it is a autosomal dominant inheritance and heterozygous, and it's a pathogenic variant. And this is an example on how larger gene panel can add also when we have phenocopies or phenotype intrafamilial variability of the phenotype. And usually you can find the list of genes that have been tested. And this is also very important because you can look if all the genes known at that moment have been analyzed. But I'd like to remember that also genomic disorders, so microdeletion or microduplication, can be responsible of CKD in patients, not only in pediatric cohorts, but also in adult patients. And here is this paper from the group of Professor Garavi, where they have found that 1% of adult patients with CKD had a microdeletion or microduplication syndrome, being the 17q12 the most frequent. And this is a case of our clinic. In this case, these women came to our attention with a CKD stage 3B with normal ultrasound, normal kidneys, negative urea analysis, extrarenal manifestation, hyperuricemia, gout, genital tract abnormalities, and facial dysmorphism and mild cognitive impairment. And what you can see from the family tree is that there is an autosomal dominant, adult onset, slow progressive chronic kidney disease with extrarenal manifestations. So we have performed a NGS analysis of a very large kidney genes panel, about 400 genes, but no pathogenic variants was identified. So in our protocol, we usually perform MLPA for HNF1 beta in case of tubular interstitial kidney disease as the patient. And we have found a gene duplication of HNF1 beta. So we thought, you know, that the gene is localized on chromosome 70 on the long arm, and it is possible that the duplication is larger. So we have performed chromosomal microarray analysis, and the larger duplication was found. And here is highlighted the region of chromosome 17 q12, and you can see that there are 15 genes, and HNF1 beta is inside this region. So how can we see this result? This is what you will see in a result of a macroarray analysis. And what you will find here is that there is a gain of copy number in this region, that is 17q12, starting from this base pair until this. And you know that there is a duplication because this portion is 3 times repeated, and this is the size of this region. is classified as a pathogenic. And this is the related syndrome, that is a microduplication 17q12 syndrome. And this is the comments on chromosomal macroarray. And as you can see, there is an explanation of the type of duplication found. So there are some challenges when we perform our diagnostic testing. We have to remember that genes are not just exons, so we also have deep intronic variants in non-coding region of our genome, and there are some examples as in Alport syndrome or Fabry disease, and so we have to think that maybe whole genome analysis will discover these variants. And also there are limits in NGS analysis, for example, for tandem repeats that are difficult to analyze. And an example is the MAC1 gene that I report here. What you can see is that there is a 16 nucleotide repeat in exon 2, and the variant that has been identified only in 2013, because it was very difficult to find it, is a duplication inside this nucleotide repeat that lead to a frame shift mutation. So different method analysis has been tried to perform to look at this type of variant, but NGS analysis usually do not see this type of variant. Now there are some new bioinformatic pipeline that combine VN-typer and with exome data. Maybe it will be possible also in other laboratory to find this type of variant. And I remember that MAC1 is the second cause of ADTKD. So genetic testing is important because it has a diagnostic value, a prognostic value. It's important for disease-modifying therapies and reproductive issue. I just want to remember, if we look at prognosis, PKD variants, for example, are divided in two main groups, non-truncating and truncating variant. And we know that there is a correlation between not only the type of gene, but also the type of variant with disease progression. And also, is important to have a diagnosis because there are conditions that we have target therapies that are amenable. And there are other cases where if we find, for example, an Alport syndrome, a genetic cause of the glomerular disease, we can avoid immunosuppressive therapies. And also there are conditions that are at risk of recurrence. And we can look for extrarenal manifestation if we have disease where extrarenal manifestation are possible, and also for prenatal and preimplantation diagnosis where we have to we need to have the type of genetic variant. And finally, this paper that look at the clinical utility and not only on the diagnostic yield of exomes. And I want to highlight this, that exome analysis in these patients with a positive results impact on management in 90% of the patients. It changed treatment plan, impact family planning, and provide information to other risk family member. So my take-home messages is that genetics is increasingly important for proper clinical management and prognostic issues. And diagnosis, it can be challenging, a diagnosis of a genetic condition, but next generation sequence has changed our genetic diagnostic workup. And what is important is the deciphering of the observed variant and to the interpretation. And so guidelines are important and mandatory, but it's essential also the professional judgment of the clinical scientist to classify. And finally, we need a multidisciplinary approach and a personalized approach to the disease for our patients. So thank you for your attention, and I will be happy to have a question from you.
Thank you very much, Claudia, for this very clear and complete talk from the basics to the gene and all the situation and clinical case. Thank you very much. If I may summarize from a nephrologist point of view, I will say that really the key points are that we need to choose the right test based on the clinic, and choosing the right test is not very easy and things are evolving. And we have to remember for some special disease, as you perfectly explained about MUC1, for example, to choose the correct test. We need to understand the tools, the ACMG classification, the ClinVar variants especially, and then we need to provide the correct interpretation, and it's maybe hard, especially. Albertien and Beata, do you want to highlight some things also?
Yes, well, you correctly mentioned, well, first of all, Claudia, congratulations on your very nice presentation and also on staying perfectly on time. One of the things that I think is very important is this classification. In the ACMG classification, there is this item that scores the patient phenotype. So if it's a suspect variant of unknown significance, then maybe if the phenotype is very fitting, it might become a class 4 variant. So it's very important that in your request you write what the key features of the patient are. So yes, the phenotype is there, but still, when you receive the result, it's extremely important to interpret this result. There are many examples where a variant might be a class 5 variant because it was published before, because it was proven functionally, etc., etc., etc. But sometimes these variants are not 100% penetrant, or the disease does not fit. And then, yes, they might carry a class 5 variant, but it might not be the cause of the disease. So I think it's important to distinguish the variant classification, and this is what in most countries happens in the lab or in the lab results. So the most cases, the people that do not see the patients, and then the variant interpretation, which is often performed by the clinician, and in the ideal world, in a multidisciplinary meeting where the both meet. But it's good to keep these things, the classification and the interpretation, as separate things. So back to you, Lucile.
Yes, in fact, I think that the new updated classification and interpretation from ACMG will define this, that there is not not to report a link between the pathogenic variant and the disease. Right, but if you classify a pathogenic variant, yes, then you have to see if it's related to the disease that you are facing with.
Yes, lovely. From also warm words from my side, Claudia, for your beautiful presentation. I would like also to emphasize the fact when sometimes you get the result that is negative, so not a single variant is found, not even those VOSs. And you shouldn't be disappointed with genetics at that point. You should remember that 2 questions should be asked at this moment. First question is, did I choose the right test? And that was one slide that Claudia was discussing, that we have a number of different tests that you can use for this matter. And the second thing is that you should also understand that all the techniques that we are using have limited sensitivity and specificity right now. It is like flying to the moon back in 80s, in 60s, when they took a black and white camera and they shoot pictures that there are no aliens there. But we know that if we fly to the moon today, we would take a 4K super high AD camera and also prove that there are no aliens. So in case you have an old test that is negative, go back to the clinic again, to the genetic clinic, and ask them whether they have a more sensitive test today to offer to your patients. Do not surrender to a negative test, and do not say, oh, it's not genetic because it's not a genetic disease because the test is negative. Just stay in touch with the clinical clinic for follow-up on that. Back to you, Liz.
Thank you very much. We start to have amazing questions. So for the participants, you have the Q&A where you can write your question. There won't be a live question. You just have to write it. So I will start with a question about truncating mutation. Some participants ask, what does that really mean, truncating mutation, and how can you see it on your report? And especially it's important for PKD on one patient. Maybe Claudia, you can explain again.
Yes, as I showed before, there are some of single nucleotide variants that change the type of DNA sequence, and we will have a protein that is truncated and non-complete, and this is a protein that will not function. And these usually are nonsense variant or splicing variants or framesheet variants. These are the categories. Or we have a deletion of the gene. These are usually the variants that are truncating. And if you use the paper that I've mentioned at the beginning, you can understand what are the type of variant. Some laboratories report also in PKD if it is a truncating variant or not. And I think that they are asking because there is a prognostic yes
and it,
fact. Yes,
it may change the treatment also.
Yes. Yes.
We have some question about the VUS variant of unknown significance. It's a real problem in our consultation to know what to do with this. We already talked about that. So what should we tell to the patient, and how often could we ask database or geneticists if our VUS from 5 years ago is still a VUS or it has changed? How can we manage this?
We usually check for the VUS every 2-3 years. So we say to the patients to come back to us, and so we can analyze again and try to see if something changed. But first, we if we have an autosomal dominant disease, we look in parents if it is inherited. For example, before we were talking about PKD, if we have a familial disease and there is one of the parent that is affected, then we can study, we can see if the variant co-segregate with the disease, and this is another little step, but usually we go to uncle or other nephew because we need to check that is not by chance that the parent has the same variant. And this is usually what we do for VUS. And we usually every 2 or 3 years look also our internal database, because some variants are more frequent in some local population, and so maybe in the genetic lab they have found again the same variant, and that is another way to look.
Yes, but I would like to emphasize here that we had a big discussion on KDIGO meeting a few years ago, regarding who should take care of VUSs, and decision was that we cannot rely on genetics laboratories to look for VUSs for us and call us back 5 years later. It is the primary doctor who takes care on daily basis of the patient, and the patient himself, herself, who should worry and who should inquire every 2-3 years about the reclassification, because otherwise the only task of the laboratories would be to reclassify the old results. So please take home message that it's the task of nephrologists or the task of patients to remember about the VUSs and ask us to reclassify this from time to time.
Yes, sure. We say to patients that they have to ask for another visit, usually to a clinical geneticist or nephrologist, and then we will ask again to the laboratory.
It's very important that we have more and more data about those, so probably a lot of patients will be classified in a few years. A question of we also have every time in clinic, if one member have positive genetic analysis and you have the diagnosis, and another one in the family have the same phenotype, for example, HNF1 beta, should you test everybody in the family, and how do you do? How do you do this? Do you do a genetic test for every person in the family with the phenotype, or you just do for the proband, and the other one you assume that it's the same genetic and don't look for the variant?
Usually what we do is quite simple, because with the Sanger sequencing, if we have a single nucleotide variant, we can ask to test for the variant. And I think that is important to confirm with the genetic testing, the diagnosis, and not only clinically. Also, I think that especially for HNF1 beta, which is a very wide type of we have a wide type of clinical manifestation. So I think that this is important. We say to the patient that he can inform relatives that there is this possibility to test, and they come to our attention, and after a visit we look for the clinical phenotype, if present or not, and then we test. This is our protocol usually.
Yes, I believe Albertien will definitely add to this. I just want to stress that please remember about the patients that they have also right not to know. So we cannot decide for the patients whether they want to be tested, but we should offer the family members the test and offer the genetic consult before the test, so they can make their own decision on sharing this information and having family members tested. There are also internal country-to-country different regulations regarding testing of children to, especially if the disease is of late onset. But I believe Albertien has some more thoughts on that.
Well, yeah, so especially testing relatives when there's a confirmed healthy relatives when there's a confirmed disease in the family, that is something that in most countries is not something that is done by the general organ doctors, but more by the genetic specialist. And how you define a genetic specialist, that can be local differences. In some countries, that might be a clinical geneticist who's expert in nephrology. In other countries, it might be a nephrologist expert in genetics, but usually not the general medical specialists. When patients have features that are fitting with the diagnosis, or sorry, relatives have features, that's a different story. And there, I think what Claudia says is very right, that usually the Sanger sequencing, that's not too expensive, so it's not too difficult. But when there's scarcity at hand, when you really have to either focus your budget or your time, then you might consider, when it's super fitting, to not test all affected if everything fits, but then you have to be very critical on whether it fits. And I saw one question in the chat from Groningen. oh no, not from Groningen, from somewhere else. That kind of alludes to this. Should every patient with ADPKD be genetically analyzed? Because we know that is a hot topic. And usually from the nephrologist perspective, they say, well, I don't need the genetics to make the clinical diagnosis. Often that is true, but we find much more atypical cases than we thought that were there. And genetic testing is often the only way to find them, because the clinical criteria are not so well upheld all over in general practice. And I would argue, and then that comes back to these families again, that you should also for ADPKD consider at least testing one in the family. And then when it fits with all the phenotypes, then you might consider not testing the others, the other affected. But it's, again, very important to be critical about this is about variant interpretation. Also, what does it mean for family members? Beata, was this what you hoped I was going to say, or did I forget something?
Yes, I would also emphasize testing children or
Oh, yeah. That's also for experts. Yeah.
Definitely, because we try to protect our children, and usually parents really want to take the decision already in advance. But especially if this is the disease that there is no intervention. We had this discussion, and this is why I was pointing to Albertien when we were discussing the collagenol 4 heterozygous or dominant carriers, whether their children should be tested or whether those children should be grown to the age when they can make the decision on their own. Please remember that patients also have the right to know, but also right not to know. They will make their decisions. They will make the insurance-wise decision, job-wise decisions, and having a burden of low penetrance disease may be harmful to them also. So it's something to be discussed by professionalists, maybe also with the help of psychological support, whether they should carry this message already, or whether we should wait and see how the phenotype in this particular member of the family develops.
Yes, I would say that usually when we have a late onset disease, we wait for after in the adult age, young adult age, and not in children to test. While if we have a childhood onset disease, so we are obviously, but if we talk about adult kidney disease, we usually not test children. And I would like to specify that genetic testing is important. Maybe I think that in PKD or other genetic disease, if we have a couple that want to perform PGT analysis or prenatal diagnosis, so there I have to test and confirm the mutation. So it depends. It is very important to have a visit with a specialist on genetics, or to decide each. I think that each patient has a different history, and we should not test all the patients, but the one that need that answer and that test.
Thank you very much. The children question is very, very important, very tricky too. With patients who will receive a kidney transplant, sometimes genetic is not performed because nephrologists will say that it's not needed because the kidney is out of out of office. What do you think about genetic in patient with undetermined CKD? Should we do whole genome, exomes, panel? Should we do something else?
But well, I think that a diagnosis is important for each person. So if we have the suspicion that is a genetic disease, we should do it. We also have some genetic kidney disease that we can have a recurrence after transplantation, and this is important. And also now we know that there are some genetic conditions that can modify the treatment after transplantation, and that is another issue that is important to look at. For example, in HNF1 beta, if we know that the diabetes can be present after kidney transplantation, and for these patients, the probability is higher. And recently, the group again of Professor Garavi published a nice paper on a panel for comorbidity in patients with CKD, in patients that will perform a transplantation, and they have found they look for cardiovascular disease, for malignancy, because we know that immunosuppression, obviously, if we have a patient with a variant in a gene as BRCA, or a gene related to cancer, it is possible to tailor the treatment. So this, I think, that could be in the near future a good tool also for patients that have to perform a kidney transplantation.
Do you have something you want to add, maybe?
Yeah, I was thinking, and I know this is often this part of the field is often felt like it's difficult, but I can assure everybody that if you do it every day, it's not so difficult. It's like analyzing complex electrolytes in transplant patients. I don't do that every day, so I think that is difficult. Yeah, well, I see Lucile nodding, but so it's just a matter of perspective. But one of the things that I think, or one thing that maybe could be highlighted even more. So Claudia very clearly made the difference between targeted gene panels and whole exome sequencing and whole genome sequencing. And I don't want to complicate it further, but I think it's important to realize that I'm sorry for the background noise if that's disturbing. That the often used test, especially in I probably shouldn't say the Western part of the world, but what I mean is the very developed countries, is that you bioinformatically filter gene panel data from whole exome sequencing data. And this is something that is, well, first of all, used a lot, and it has a lot of advantages because it means you can reanalyze the whole exome sequencing data. And later, our lab is going to change to whole genome next year. So then we can do the same from whole genome. So you can do reanalysis. Again, I think it's important what Beata said, that the treating physician or the patient needs to come back, because it's impossible to keep track of everybody that wants a reanalysis. But what is also important is that often people that don't do this every day, especially when there's a negative result, they will say the WES was negative. And then I don't have a clue. I don't have a clue because usually it's the gene panel that was taken from the WES and not the whole of the whole exome sequencing data was performed. So especially when talking about negative tests, it's extremely important. Like Claudia said, she showed you the gene list, but it's also important to mention what the background of that test was. And also maybe, and this is a little tip, most people these days have these electronic health records where you have this medical history with the years and the dates, and when did the transplant fail for the first time and when was the second transplant, blah, 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 blah. But then if you put there 2024 large CKD panel from WES was negative, reanalyze in 2027 or something, then it will have these electronic health records are built in a way that this pulls, that this comes up, even if you are not the doctor of this patient in 2027, if they stay in the same hospital, it will be in the list. So this helps make the department aware of the patients where that are suspect or that had testing or that might need reanalysis. So what this would be a tip to put it in your medical history list in your electronic health record.
And we had a question in the chat about should every patient will be retested every 5 years or something like that. But I think it depends on what you find in the first analysis. And as you said, Albertine, and we have to check regularly our patient and see if if things have changed and if we have new data to reanalyze. But for some patients, we won't find anything for like 20 years or maybe more. But from over 6 months later, you find a new gene or a new virus that is classified, and so.
Yeah, but you can be in touch with the lab about that. So if you're not comfortable with all these changes yourself, what we usually say in patients that are not super suspect, that are not bound to have children and that want PGT or something, come back in 3 to 5 years. Usually the technical developments are so big that it makes sense to be in touch.
And we had a new question to clarify again about the Sanger test. Is it the most performant one? Yeah, maybe you can detail because it
Yes, no, it's not. Maybe it wasn't clear on my slide, but no, Sanger sequencing is a test that we use when we want to test for a single nucleotide variant, a known variant, and we do not use that anymore to test for an entire gene. Okay. So no, this is the answer. And I want to say about the last question that the probability to find a variant in a patient depends on the clinical phenotype. We have a different categories of kidney disease, and the yield, the diagnostic yield is not the same. So if we have a clinical picture of polycystic kidney disease and large kidneys with several cysts and autosomal dominant disease, it's a high probability to find. But there are some, for example, tuberous interstitial kidney disease, we do not find a variant in half of patients. So if we do not have family history, it depends on clinical phenotype, age of onset. There are a lot of issues that we have to look. And a lot of patients I see now that perform a genetic analysis, but the probability is very low. So they should not repeat maybe in 3 or 4 years. But in other type, another subgroup of patients, yes. And again, it depends on the patients, and there are really a lot of different scenario. And so it has been, it's important to see the patients and evaluate single cases.
Thank you very much. I think we are running out of time, even if we can continue for hours to reply to a question. So I may say that maybe the thing that I will really also remember as a nephrologist is that we need to work together with a clinician and geneticist to really ask correct interpretation for our patient and don't forget genetic. I don't know, there are some other questions in the chat. I think we will try to write it down, but I'm not sure we can reply to everything. And I thank you very much for your attention. I thank the speaker, Claudia, very interesting talk, and Beata and Albertien for this really great discussion. And thank you, Eerde, for having this Gene and Kidney Group and YNP seminar. Thank you.
Thank you.
Thank you very much. And if I can have the very last note, for those who are looking for information on rare kidney diseases, genetics in particular, there is ERCnet and the ERCnet website where you can find a number of information on this. So European Reference Network for Rare Kidney Diseases. So you can look for us there. We are experts also in this association, and we are sharing our knowledge and offer also some consults. So you can look over there or through ERA, of course.
Thank you. Bye.
Bye.